Alright you guys, welcome back to another video lesson from ICU Advantage. My name is Eddie Watson, and my goal is to give you guys the confidence to succeed in the ICU by making these complex critical care subjects easy to understand. Alright everyone, this lesson here is going to be the complete ECG Rhythm Interpretation series, all in one video. All 6 lessons from that series are here back to back, and we'll cover everything you need to know about rhythm interpretation, from the basics on the conduction system, steps to interpretation, and the various rhythms, arrhythmias, and blocks that are essential for you to know. Now, if you want to earn CE credits for watching this series, then you can simply become a member of ICU Advantage Academy over at icuadvantage.com/academy, or following the link down below and joining there. As an Academy member, you'll also have access to the brand new and beautifully designed premium notes that I'm currently working on. That said, you can pick up a copy of these premium notes by following the link down below as well. Now, if you don't want or need CE credits but still would like to access the original style notes, you can also become a YouTube or Patreon member and access all the notes for the entire channel over there. You'll find links to both of those down below as well. I hope you guys enjoy this master cut on building a solid foundation and rhythm interpretation that's really essential for you to know. Alright, I want to welcome everybody back to another video lesson from ICU Advantage. And this is going to be part 1 in our new series of lessons covering ECG or EKG rhythm interpretation. And in this lesson, we're going to cover the conduction system of the heart. Alright, welcome back everybody. Like I said, this is going to be the first lesson in a new series of lessons that we're doing covering ECG or EKG rhythm interpretation. And for those of you who don't know me, my name is Eddie Watson and I'm going to be presenting this lesson for you. Alright, so let's go ahead and dive on in. And so like I said, in this lesson, we're going to be talking about the conduction system of the heart. And in order to really be able to understand what's going on with your patient in terms of what you're seeing on their ECG rhythm strip, it helps to really have a good foundation in understanding the conduction system that really makes that all possible. And so we have a diagram of the heart here, and I'm really going to use this to show you where this conduction system is, explain about it, and help you to have a good understanding of what's going on in the heart with this system. And so I'm going to go ahead and label some parts on here so that we make sure we're looking at this in the same way. And so the first thing I'm going to label is our right atrium, our right ventricle, our left atrium, and our left ventricle. Now, as we know, these are the 4 major chambers of the heart, and the blood flows through these chambers out to various parts of the body. In addition to that, the blood flow also will flow through our tricuspid valve, our mitral valve, our pulmonic valve, and our aortic valve. Now, I'm not going to spend much time here and really talk about the flow of blood through this system. In fact, we have a really great lesson that actually goes through all of this in detail within our hemodynamics series, which I'm going to go ahead and link to up above. But it does help to have a good understanding of that blood flow as well, because ultimately the conduction system, the whole point of that is to ensure that that blood flows through the system. Now, one last thing I do want to get into before we really get into the meat and potatoes of what we're going to talk about here is I do want to cover some basic terminology that's going to be important. And for this, we're really just going to be talking about 2 things. The first of these is what we call depolarization. And depolarization is the key process that makes this whole system work. And so real quick, I'm going to take a dive back into our biology, anatomy, physiology days, and we're going to talk about muscle cells. And so to really give you the Cliff Notes version, the muscle cells operate off of what's called an action potential. And so if you remember, we have all of those ions, sodium, potassium, calcium, all of these which have a positive charge. And these ions have an ability to move in and out of the cell in order to change the charge of the cell. And so if you remember, inside the cell we have all the myosin and actin, and when it receives this action potential or this change in charge, it causes these muscle fibers to shrink down, reducing the size of the cell, and what essentially creates that contraction. And so as these cells depolarize, essentially they contract. And so really we can think of depolarization as our contraction. Now, the other bit of terminology that I want to talk about here is going to be our repolarization. And so after that action potential has happened, the ions have shifted and the cells have contracted. Eventually those ions start working their way back in. The actin and myosin release, causing the cell to move back out to its original size. And this is what we call our relaxation. And so like I said, these terms are going to be very important as we get to talking about what's happening within this conduction system. But just remember, depolarization means we have contraction happening, and repolarization means we have relaxation happening. And so it's also important to note that when this is happening in the ventricle, this contraction is what we call systole. And again, within the ventricle, when we have this relaxation going on, this is what we refer to as diastole. Alright, so we've got that stuff out of the way. So let's go ahead and jump into really talking about the pathways and how this conduction system works. And so the first of these things that we're going to talk about is a special collection of cells that are located over here in the right atrium. And this collection of cells is what we refer to as the sinoatrial node, or oftentimes you'll just hear it called the SA node. And this SA node, you're going to hear it referred to as the pacemaker of the heart. And the reason for this is these specialized cells actually have the ability to depolarize on their own. And this depolarization causes an action potential that moves out away from them. And this is something that we refer to that's called automaticity. And so like I said, when that action potential happens, this is going to spread out to all the surrounding cells, causing all of those cells to depolarize as well. And in fact, most cells in the heart will only depolarize when a neighboring cell depolarizes. And so that's what makes these cells so special, is they have the ability to depolarize entirely by themselves. And to even make this cooler, this depolarization happens at a pretty consistent rate. And in fact, the cells in the SA node will depolarize all by themselves at a rate of about 60 to 100 times per minute. And this rate can change as a result of various influences. You can have influence from the sympathetic or the parasympathetic nervous system, which we do cover quite thoroughly within our lessons on shock. Again, I'm going to link to up above. But also this rate can be influenced by some sort of problem or condition and ultimately change the rate in which these cells are depolarizing. And so as those cells depolarize, you get that wave of depolarization that flows throughout the rest of the atrium, causing the cells of the atrium to contract and thus ejecting blood down into the ventricle. Now, one thing to note though is this spreading of depolarization between cells is not the fastest process. It works great spreading that signal from the proper direction slowly throughout those cells so that you have a nice coordinated contraction. But sometimes you need to get that signal to other places a little bit quicker. And an example of this is here we have the SA node is over in the right atrium, but we also need the left atrium to be firing at the same time. And so there's actually a special pathway that kind of goes from the SA node and comes into the left atrium over here and helps to spread this signal out. And the specialized cells that make up this pathway carry that signal very fast. And this pathway that we have here is what we call Bachmann's bundle. Again, think of this as a highway for that signal to spread from the SA node in the right atrium over to the left atrium in order to begin that process of depolarization and thus contraction. So now moving from there, there's another area of specialized cells. And these cells are found down here in the atrial septal wall. And these cells are what we call the atrioventricular node, or you'll often hear it referred to as the AV node. And the AV node, oftentimes you're going to hear this referred to as the gatekeeper. And the reason for this is the AV node's job is to take that signal that originated in the SA node and pass that signal along throughout the rest of the conduction system. And the way that it gets this signal from the SA node is through the use of 3 pathways. And we call these the internodal pathways. Essentially, all these do is take that depolarization that's happened within the SA node and ensure that it gets to the AV node so that the AV node can continue to pass that along. Now, the cells that make up the AV node, they're actually pretty specialized cells too, and they have that same automaticity that the cells in the SA node have as well, although these ones fire at a slightly different rate. So in the off chance that they aren't receiving signal from the SA node, and they can fire with their own intrinsic rate of 40 to 60. But like we talked about, really the AV node's primary job is to be that gatekeeper of the signal from the SA node. And so there's one really important thing that this node does, is when it gets that signal from the SA node, is it's actually going to delay the conduction. And so it's going to receive that signal, and it's going to hold on to it for just a little bit before it passes it on to the rest of the system. And it usually delays this about 120 milliseconds, or 0.12 seconds. And this delay is absolutely vital in the functioning of this system. The reason for that is, by having this delay, it allows for the full contraction of the atria, as well as the closure of the tricuspid and the mitral valve, before sending that signal along to the ventricles to contract. And it's pretty amazing that this happens, because by having this little bit of delay, it prevents the atria and the ventricles from really working against each other, and it keeps that blood moving in the right direction, first from the atria to the ventricle, and then from the ventricle out to either the lungs or the rest of the body. And so really, without this delay, this flow of blood wouldn't work. And so after we've had this delay, the AV node is going to pass that depolarization down into something that we call the bundle of His. And the bundle of His is located within that ventricular septum. And you can think of the bundle of His as this high-speed transport system that we had just talked about. It allows the conduction of those signals to happen very fast. And it will take this same signal of depolarization that started all the way up in the SA node, which has come through the intranodal pathways to the AV node, and will now carry those throughout the ventricles. And again, it does this very quickly. And the bundle branch is actually going to split into two separate pathways. We have our right bundle branch and our left bundle branch. And then from there, the left bundle branch is actually going to split some more and take this into our left posterior fascicle and our left anterior fascicle. So it's going to ensure that this signal gets to both the back or the posterior side, as well as the front or the anterior side of that left ventricle. And so we have those bundle branches which come down, and again, they really provide that fast transport of that action potential. And then so finally from there, we're going to have these extensions off of these bundle branches and fascicles, which we call the Purkinje fibers. And so the whole point of these Purkinje fibers is to take that signal to the correct area, or the correct part of the ventricle, in the correct order, and this is what allows for that organized contraction of the ventricle, ejecting that blood either out into the pulmonary artery or the aorta. And so by sending the signal down that bundle of His into our left and right bundle branches and out through these Purkinje fibers, you get that very uniform, proper contraction, again, keeping that blood flowing in the right direction. And finally, once again, the cells that are within the bundle of His or the Purkinje fibers, they are also specialized cells. And if they're not receiving a signal from the AV node, they also have that same automaticity to be able to have their own intrinsic rate. And so here, if we're not receiving that rate from the AV node, we're going to have an intrinsic rate of 20 to 40. All right, so that there is the overview of the conduction system of the heart and how it works. As a quick review, we have that signal that originates, that depolarization that originates from the SA node is carried out through the atria, aided by Bachmann's bundle to get over from the right atrium to the left atrium, causing contraction in those atria, pumping blood into the ventricles. At the same time, that signal is moving across those intranodal pathways and reaching the AV node, or the gatekeeper, in which this delay is going to happen to that signal. And after that delay, that signal is going to go out into the bundle of His, into our left and right bundle branches, our left branching into the left posterior fascicle and the left anterior fascicle. And from there, it's going to carry out into those Purkinje fibers and get to all the parts of the ventricle very quickly in the right timing and right order to cause that organized contraction, ejecting that blood out the ventricle into either the pulmonary circuit to go to the lungs or into the aorta to go out to the rest of the body. It's really a pretty amazing system that we have here, and the way it all comes together in order to just make everything work and keep that blood flow going in the right direction and moving throughout our body. I hope this all made sense for you guys. I hope that you have a better understanding of what's happening in this electrical system, because like I said, in order to really know what's happening when you're looking at your patient's rhythm strip, you have to know what's happening underlying to give you those electrical signals. All right, you guys, welcome back. Like I said, this is going to be part 2 in our series here on ECG and EKG interpretation. And in this lesson, we're going to give you a breakdown of the 5 simple step method in order to interpret your ECGs. And as always, for those of you who don't know me, my name is Eddie Watson, and I'm going to be your presenter for this lesson. All right, so the 5-step method, you're probably wondering what the heck is that? Essentially, this is going to be a very simple set of steps that you can go through when you're looking at your patient's ECG in order to help you break down the parts that you need to know in order to be able to interpret it appropriately so that you can figure out what's going on with your patient. And so to start out, we're going to go through a couple basic concepts here. We're going to cover some information that you need to know in order to be able to do this ECG interpretation appropriately. We're going to cover the different parts of what a normal rhythm is supposed to look like and what parts of that you need to know and be able to identify. And so really to start out here, the first thing that we need to actually cover is to go over some basics about the ECG grid paper that the rhythm strips are going to be on. So this here is just a small sample of what a typical rhythm strip will print out on. And so if you look carefully, every time you have 5 of these small boxes, it actually forms a thicker line and makes one of these large boxes. All right, and so we can see here that this is one of the small boxes that I'm talking about, right down here. But if you look closely, going from about here to here, this is actually that collection of 5 boxes that I was just talking about, and what formed to make one of the large boxes. And the nice thing is these boxes aren't there just to make things look pretty and to line up. They're actually a unit of measurement. And what they're measuring here is time. And so essentially, if you measure or count the number of boxes going this direction, you can actually get a measure of time on what you're seeing on your ECG strip. And so if we look at our small box here, every single one of these small boxes is going to be 0.04 seconds. So from here to here is 0.04 seconds. Now, if you do some basic math and you take a look and see that you have 5 of these small boxes forming a big box, then you can come to the conclusion that you have 0.2 seconds going from here over to here. And basically what we'll do is we'll use these boxes and look at the ECG rhythm that's printed out against them and use those to determine how much time is taking place on certain parts of that ECG rhythm. Now I do want to show you what a typical rhythm strip will look like. And so this is an example of what the paper is going to look like if you print out the patient's rhythm strip. Now one important thing that you're going to want to look for on these is you're going to want to look for some dashed lines up at the top. So if we were looking at this strip here, we would actually see a thick hash here and another thick hash over here. And then right in the middle between these 2 big hashes is you're going to find a thin hash. And so basically here is you have one of these marks happening every 1.5 seconds or every 15 big boxes. And so here we can see we have 2 sets of 15 big boxes, which means that the strip that we're looking at here is a 6-second strip. Now this will come in play here in a little bit and be important for you to know, but for right now just know that the time in between 2 of these big hash marks is going to be 6 seconds. All right, so now that we got that measuring part out of the way, let's go ahead and start to cover the different parts of the electrical signal that you're going to see when we're looking at a normal sinus rhythm. Now to go along with this, in our last lesson, we went pretty in depth talking about the conduction system of the heart, which I will link to up above for those who haven't watched it. So I'm not going to go detailed into that here, but as I'm going through and drawing this normal rhythm, I'm also going to follow along and kind of show you in the conduction system where this is happening and what this actually means in terms of what's going on inside the heart. So on our diagram of the heart here, I do want to draw and label a few of these parts for you guys within the conduction system. So over here we know we have our SA node. Coming off that, we have Bachmann's bundle, which is going to spread that signal out to the left atrium. Located roughly about here within the atrial septal wall, we have that AV node. And then don't forget we have those 3 intranodal pathways carrying that signal from the SA node to the AV node. Then coming down off the AV node, we have the bundle of His, which is going to split into our left and our right bundle branch. The right bundle branch is going to come all the way down and service the right side of our heart. The left bundle branch is going to split once again, and it's going to split into our left posterior fascicle and our left anterior fascicle. Both of these servicing the left side of the heart and ensuring that we get that signal all throughout that left ventricle. And finally, coming off of these bundle branches, we're going to have our Purkinje fibers, which again are going to take that impulse, that depolarization, and spread that evenly and organized throughout the ventricles. Alright, so let's go ahead and start taking a look at a normal ECG rhythm. And so the first thing that I want to draw in here and really make mention to you guys is something that we call the isoelectric line. And basically what this line signifies is our neutral no charge. And so really you can think of this as our baseline. And anything above the isoelectric line is going to be a positive charge, and everything below the isoelectric line is going to be negative. And this positive and negative is oftentimes going to depend which leads you're using, but for the purpose of this example, we're going to consider that this is lead 2. So now the first thing that we're going to see, if you think back and remember, we have our SA node, which is going to depolarize on its own, sending a signal out throughout the atrium. That signal is also going to travel along that Bachmann's bundle, and at the same time, it's going to be depolarizing the left atrium as well. And so if we go back and look and see what we're actually going to see on our strip here, is we now have a depolarizing event that's taking place, and so we're going to see a bump form on here. And so essentially, as that wave of depolarization moves across the atria, you're going to see that wave of signal move across your ECG tracing. And this here is what we are going to call our P wave. So now if you remember, we have those signals now which have worked their way through these internodal pathways and reached the AV node. And the AV node, being that gatekeeper, is going to take that signal and it's going to hold on to it. Again, ensuring that we don't have that competition of the atria and the ventricles both contracting against each other at the same time. And so what you're going to continue to see is flat along the isoelectric line here. And so now after the 120 milliseconds, the AV node is going to pass that signal along down the bundle branches, heading out to the ventricles via the Purkinje fibers. And with this happening, this is where we're going to see the next bit of changes on our ECG strip. And so now here you can see that this wave is going to be much bigger than that P wave. But if you really think about it, those ventricles are a lot bigger and consist of a lot more muscles than the atria do. So that explains why we're going to see a big wave showing up as that depolarization happens. And so within this wave, you're actually going to see 3 different waves. We have our Q wave, our R wave, and our S wave. And together, these form our QRS complex. Now, one thing to note is you're not always going to see a Q wave or a defined S wave. And so really the main thing we're looking for is that R wave, and we'll get to that here in a bit. But for the purpose of this perfect normal sinus rhythm that we're going to use as an example here, we're going to have all these waves in here. So once again, we're going to be back on our isoelectric line, and we're not going to see anything happen for just a little bit here. And then from here, the next wave we're going to see is going to be a little bit bigger than what we saw with our P wave, and then continue along our isoelectric line. And this final wave on here is what we call the T wave. And really what's happening in the T wave is we've now had that ventricle that has depolarized, and all those ions have shifted out of the cell. And so after that depolarization and contraction has taken place, everything is going to relax and those ions are going to move their way back inside the cell in an event that we call repolarization. And so this T wave that you're seeing is actually the repolarization of the ventricles. And so you might look back at our rhythm that we have here and be thinking, oh, I don't remember them talking about atrial repolarization. And in fact, you'd be right, because we didn't. And the reason for that is the atria, they do repolarize after a depolarization and contraction. But the problem is that the atria are repolarizing at the time the ventricle is depolarizing. And so as you can see, when we look at the ventricular repolarization, that T wave is significantly smaller than our QRS complex. And so our atrial repolarization would actually be much smaller than even our P wave. And in fact, it's in there, it's just being buried and masked by the giant QRS complex that's taking place. So both the atria and the ventricle are going to go through a depolarization and repolarization phase, but the only one that we're going to see on our ECG tracing is going to be our ventricular repolarization. So now on this strip here, there's all sorts of different parts and areas of this that we can give measurements for. But really for our basic interpretation, which is what we're going to be covering here, there's only going to be two segments that we really care about their time. The first of these is going to be what we call the PR interval. And essentially, the PR interval is going to go from the start of our P wave and will end at either the start of our Q or our R wave if we don't have a Q wave. And so essentially, we're looking at this whole section here, and this is going to be our PR interval. Now, the other interval that we're going to look at is the interval of our QRS complex. And so that's going to go from the start of our Q wave to the end of our S wave. So that's going to cover right across here. And like I said, that's going to be measuring our QRS. Now, there is one last interval that I do want to point out and kind of make mention of here, but we're not really going to talk about it much in this lesson. In fact, that's really going to be geared towards another lesson that we'll probably do in the future here. But there's this segment right through here, which is our ST segment. And as you can see here in our example, after we went through the entire ventricular depolarization, we came back to that isoelectric line before going to our T wave. And so sometimes you might see a depression of this ST segment, or sometimes you might actually see an elevation of the ST segment. And these are important to monitor for because they can be signs of either myocardial ischemia or myocardial infarction when we're looking at the elevation side of things. But again, I just wanted to make mention of that. We're not really going to talk about that any further in this lesson. Like I said, for this lesson, the main thing you want to focus on is the PR interval and that QRS complex length. All right, so I hope so far this has made sense for you guys. Like I said, we've talked about just what a normal perfect sinus rhythm tracing is going to look like on the ECG, as well as to give you some conceptualization of what's actually happening inside the heart and the conduction system to go along with what you're seeing on the paper. All right, so now that we've got that out of the way, we're going to move on and talk about our actual interpretation, and in particular using the 5-step method. And so with this 5-step method, like I said, this is going to be a series of 5 steps that you're going to go through every single time when you're looking to interpret your patient's ECG rhythm. And by doing these 5 steps and gathering this information, you'll be able to use that to effectively make a good interpretation of what you see. And so to start off with step 1, what you want to do here is you want to locate your P wave and your QRS complex and identify those. Now again, for this interpretation, we want to be using lead 2 for this interpretation. And so when we're looking at our P wave in lead 2, we want to look and see, is that P wave upright like we drew in our example here? It's going to be important if that P wave is either not present or going the opposite direction, as that can be an indication of some sort of problem that's going on or where that initial impulse has originated from. But like I said, look and see, is that P wave present and upright? And now if you have found a P wave and you've identified your QRS complex, the other thing you want to check and see is there a P wave for each QRS complex? Again, following that path of conduction, we should have that P wave immediately followed by a QRS complex. So if you guys aren't seeing that, or you're seeing P waves without QRS complexes, or vice versa, then there could be some other sort of problem that's going on. And in fact, those are things that we are going to talk about in future lessons in this series. So pretty easy for step 1. And so moving on to step 2, if you remember, we talked about those 2 measurements that we really care about, the PR interval and the QRS complex. So for step 2, we're going to actually get those measurements. And so at this point, we've talked about these measurements, but we haven't actually given you a normal value and what you guys want to expect to see for these. So to start that off, let's go ahead and talk about our PR interval. And for our PR interval, remember, think about this is the time from the time that the atria is contracting until the time that the ventricle is contracting. And if you remember, that signal has made its way over to the AV node where it's been delayed, ideally for 120 milliseconds. And so with a PR interval, we expect to see an interval within the normal range of 0.12 and 0.20 seconds. Now, typically for simplicity, we really don't worry about a short PR interval, but if that PR interval is long, it could tell you that there's something else going on. Again, stuff that we'll talk about here later in these lessons. And so then with our QRS complex, our normal value is going to be 0.06 to 0.10 seconds. Although really, we just care that we're less than 0.12 seconds. Again, a short QRS complex for simplicity is not something that we're really going to worry about, but a long QRS complex, technically anything over 0.1 seconds, but really what we care about is anything longer than 0.12 seconds, which is going to be potentially a pathological condition that's going on with our patient. So these numbers are going to be important, and you guys are going to need to memorize these. So you might be wondering, how am I going to get these measurements? How do I know how long these are? Well, if you remember back, we talked about those boxes that are on that ECG paper. Well, those boxes tell us amount of time, and so if we just measure the amount of boxes that something is taking place at, we know how long the time is for that to happen. Now, this is my plug where I know a lot of the newer monitor systems have built-in e-calipers in which you can click and get your measurements on there, but not everybody has those, and you may be running into issues, and so it does help to know how these box measurements work in order to be able to get your measurements yourself manually. So for the first one, we're going to talk about our PR interval. So if you remember, we're going to start from here and measure over to here. And so here you can see that we have 1, 2, 3, a little over 3 boxes. We know that each box is 0.04, so 3 of them would put us at 0.12. If we went for the full 4th box, we'd be at 0.16, but we know that we're maybe roughly about halfway in here, so we're probably something like 0.14. Again, either way, both of those numbers are going to be within our normal value. And with this being a normal sinus rhythm, we would expect to see that. And so again, if we look at our QRS complex, we're going to be measuring from here to here. And we can see we start off not directly on the line. So here we have about a half a box, and then 1 box and 2 box. So we have 2.5 boxes. So again, we know the small box is 0.04 seconds. So 2 boxes would be 0.08 seconds. And another half a box, we'd add another 0.02 for a grand total of 0.10, which again falls within our normal limit, not surprisingly with a normal sinus rhythm that we have here. All right, so moving on to step 3. For this step, we actually want to look at the whole rhythm strip and make a determination of whether our rhythm is a regular rhythm or an irregular rhythm. And so in order to really show you guys this, I'm going to take you back to our 6-second strip that we talked about earlier. I'm going to go ahead and put up a full strip of a normal sinus rhythm. So don't mind the drawing. I tried to do my best in order to get everything the same and to keep it within what we would expect for a normal sinus beat here. But if you take a look at the patient's strip here, and you look at each of our R waves on our QRS complex, if you kind of follow them along, you can see that they seem pretty regular. And oftentimes, if you have some very irregular rhythms, it'll be very obvious just from looking at that you do have a regular rhythm going on. But one of the best things you can do in order to ensure that this is a regular rhythm is to take either an index card or a piece of paper and put it up against your rhythm strip. And what you want to do is you want to make a mark right where each of these R waves are. And then essentially what you do is you just move your card right along and you line them up and you see, does everything line up? And again, you move it along, continuing to check and see that each of these line up. And so in this case, you see that they all pretty much line up. They don't have to be perfect, but they all pretty much line up with the ticks that we made from the first 3 R waves. And this basically tells us that these R waves are happening at a pretty regular rate. And therefore, we would know that that rhythm was regular. So again, we want to make note, do we have a regular or irregular rhythm in step 3 here? And so now on to step 4. For step 4, we want to determine what is our heart rate. Now there are a few different ways in which we can do this. The first of these, which I call the cheater method, is you can just look and see if you happen to have a real-time strip that you just printed out on your patient, is you can look at the monitor and see what that rate says. But that's too easy for you guys. Like I said, for this lesson, we want to give you the ways in which you can actually manually calculate out what your patient's heart rate is. And so again, we're going to go to our example here with the 6-second strip. And so when we're talking about what our patient's heart rate is, what we want to know is how many times is the heart contracting in a 60-second period or 1 minute. And this essentially gives us our beats per minute. So I'm going to give you guys 4 different ways in which you can look at your 6-second strip here and determine what your patient's heart rate is. The first of these is what we call the 6-second method. And so for this method, essentially what you're going to do is you're going to count the number of QRS complexes within this 6-second strip, and you're going to multiply that by 10, because we know there's 60 seconds in a minute, and this will give you your patient's heart rate in beats per minute. The beauty of this method is it actually works for both regular and irregular rhythms. So in this example here, we would just count out 1, 2, 3, 4, 5, 6, 7, 8. So we have 8 beats in 60 seconds. We'll multiply that by 10. And here we know that our patient's heart rate is right around 80. Probably the easiest of these methods. But it's also not the most accurate because our heart rate could be a little bit below 80 or a little bit above 80. But again, for the most part, when we're looking at this basic interpretation, that little bit of variance isn't going to make much of a difference. Now the next method that we're going to cover here is what we call the big box method. Now for the big box method, what we're going to do is we're going to count the number of big boxes in between our R waves. And then from there, we're going to take that number and divide it into 300, and this is going to give us our patient's heart rate. So like I said, essentially we're going to take 300 and divide that by the number of big boxes. And again, that's going to equal our heart rate. So for this example here, let's go ahead and start back over here with this one. And here we can see that we actually have 1, 2, 3, almost 4 perfect big boxes. And so if we were to take 300 and divide it by 4, we would actually get 75. And so here's where you can see some of the difference that you're going to see between some of these methods. The last one on the 6-second method, we got a heart rate of 80. Here with the big box method, we got a heart rate of 75. Again, the difference between your patient's heart rate of 75 and 80 isn't really going to make much of a difference, but we're starting to get a little bit more accurate in terms of the number that we have here. One caveat to the big box method is this is only going to work on our regular rhythms. All right, so let's go ahead and go on to our third method here. And this one's going to be very similar to the big box method, and it's what we call the little box method. Now you probably can figure out what we're going to do here is instead of counting the big boxes, we're actually going to count the small boxes, and we're going to divide that into 1500. And again, that's going to give us our heart rate. Now, just like the big box method, this one is only going to be able to be used on our regular rhythms. And this method is really best for our fast rhythms where you're not having to count a whole bunch of these boxes. But just to make the point of having a little bit more accurate of a heart rate, I'm going to go ahead and count these out for you guys. And we're going to start from our second QRS complex. and we count out 21 small boxes. We divide 21 into 1500 and we actually get 71.4. So either rounding down to 71 or up to 72 depending on the accuracy of my measurement. But again, we see that we have a slightly different number than the big box method, and again a different number than the 6-second method. And again, I don't recommend using this one for our normal wide-spaced rhythms like this. Really, if you're looking at your faster rhythms, that's where you're going to want to use this small box method. All right, and so on to our last method of getting our patient's heart rate. This is going to be one that we call the sequence method. And for the sequence method, we're actually going to go back to counting the big boxes, but we're going to do that and count down with the following number sequence. We're going to count down and go 300, 150, 100, 75, 60, 50. And so again, if we use our first QRS complex as an example, here would be 300, here would be 150, here would be 100, here would be 75, which you can see this is where our QRS complex lines up. If we continued along, our next one would be 60, and then 50. And so again, depending how much space is in between each of your R waves, you can use this method to quickly count those, and as long as you memorize that sequence, you can come to a pretty close and pretty accurate determination of your patient's heart rate pretty quickly. Now once again, just like the others here, this is going to require a regular rhythm in order to do this. So if you have an irregular rhythm, really your only option is to use the 6-second method and to figure out what your patient's heart rate is that way. Otherwise, you've got 4 different methods, and depending on what's going on and what you want to do, or really which one works best for you, you can use any one of those and come to a pretty close determination of what your patient's heart rate actually is. And one last little thing to add when we're looking at determining our patient's heart rate, we need to know that our patient's normal heart rate is going to be between 60 and 100 beats per minute. All right, so we've gotten this far, and so that means we're going to move on to our 5th and final step in the 5-step method. And for this step, we're going to take all the information that we gathered up above, look at our patient's rhythm strip, and we're going to interpret the rhythm. And so in this lesson, we've really only talked about a normal sinus rhythm, and we've identified that by having an upright P wave, a P wave for every QRS complex, a QRS complex that's less than 0.12 seconds. With that, we'd have a PR interval of 0.12 to 0.20 seconds. We'd have a regular rhythm, and our heart rate would be between 60 and 100. If we meet all of those criteria, then we know that our patient has a normal sinus rhythm. Now, it turns out there's actually a heck of a lot more rhythms that your patient can be in. And so in the next couple lessons, we're going to talk about many of these different variations that you're going to see and how to identify those. But no matter what's going on with your patient, no matter what rhythm they're in, you're always going to start following the same 5-step method, completing that final step by making your final determination or interpretation of what the rhythm is. All right, I hope you guys followed along with all of that. I hope that I was able to explain these different concepts in a way that really makes them understandable for you, because it's really important that you guys are able to look at your patient's rhythm strip and be able to make a determination of what's going on, because sometimes depending what you see, it may require urgent or emergent intervention, and you being able to catch that and get somebody on the phone or get somebody to the bedside in order to address it can really make the difference for your patient. All right, welcome back, everybody. Like I said, this is going to be our 3rd lesson in this series of lessons. And for this 3rd lesson, we're going to really start to take a dive and take a look at the different types of arrhythmias that you're going to find your patient in. For those of you who don't know, my name is Eddie Watson, and I'm going to be your presenter for this lesson. So like I said, this lesson is going to be all about covering the different types of arrhythmias that you can find your patient in. We're going to go through all of these, show you examples of them, as well as kind of talk through sort of what some of those causes are, what some of those key characteristics or key features of that arrhythmia in order to help you identify it are. And hopefully with what we've discussed in the past 2 lessons, you'll be able to take that knowledge and kind of understand some of the conduction issues or the issues that are going on underlying some of these rhythms that you see. So I have listed out here some of the major types, and there's going to be multiple arrhythmias within some of these categories. But the major types that you see here, first we have our sinus arrhythmias. From there, we're going to go on and talk about the different types of premature beats that you're going to see. Following that up with talking about some of the bradycardic and tachycardic rhythms that you're going to see. From there, we're going to do a breakdown of either our atrial dysfunctions, our junctional rhythms, or some of our ventricular problems. And so finally, the last type of arrhythmias that you guys are going to see are what are called our heart blocks. And in fact, our next lesson is going to be a dedicated video just to those heart blocks. But I did want to list them out here as they are categorized as one of the major types. And so as you can see over here on the diagram of the heart on the right, there's really a lot of question about what area is causing the problem and where the dysfunction is that's leading to these different types of arrhythmias. So hopefully by the end of this lesson, you'll have a better understanding not only of what's going on behind each arrhythmia, but being able to more importantly identify them so that you can possibly intervene if need be. Now, before we begin, you guys head down into the comments. We'd love to hear which of these types of arrhythmias you're most interested in hearing about. All right, and with that out of the way, let's go ahead and start off with our first one here. And for this, I'm going to bring back our 6-second strip paper that we have here, and I'm going to put up an example of each of these different types of rhythms for you to be able to see it, and we'll kind of talk through, like I said, some of the ways that you can identify this particular arrhythmia. Up at the top, you'll notice our tick marks or our hash marks in order to identify the time breaks on here. So we have the 2 big hashes and the 1 small hash in the middle. Therefore, we know that this strip that we're looking at is a 6-second strip. And so the first of these arrhythmias that we're going to talk about is our sinus arrhythmia. Now, there really are multiple different types of sinus arrhythmias that kind of fit in this category, but we're going to, just for the purpose of simplicity, we're just going to talk about this generalized encompassing category. And so really to start off, when we say that this is a sinus arrhythmia, it's because this is actually originating in the SA node. And again, going back to part 2 in this series, which I will link to up above, we talk about how to distinguish a normal sinus rhythm. And the reason that we know that this originates in the SA node is because we have our P waves right here. And along with that, we've got a pretty narrow QRS complex, which are our 2 big key indicators that this is a sinus beat and it's originating from that SA node. And in fact, if we count out our rhythm here using the 6-second method, again, we talked about that in the previous lesson, we see that we have 1, 2, 3, 4, 5, 6 beats here, and therefore we can estimate our patient's heart rate to be 60 beats per minute. Now, the reason we refer to this as a sinus arrhythmia is all on its own, it actually has an increasing and decreasing heart rate, which hopefully should be pretty obvious. As you can see, our distance between these 2 beats compared to the distance between these 2 beats is quite a bit different. And again, it goes back and we have a shorter or quicker time between our beats here. And so really our heart rate is just speeding up and slowing down, and it's doing this all on its own. And fortunately, this is often a benign thing. And so really to break this down, if we have a sinus beat or a rhythm that's based off signals that are coming out of the SA node, but we don't have that consistent regular heart rate, then more than likely you've got a sinus arrhythmia. And like I said, there are different types of sinus arrhythmias, but I think that's really beyond the scope of what we're hoping to achieve in this lesson. But certainly once you master identifying these basic arrhythmias, definitely look into some of these different things that are out there, because once you've been out there and you're on the floor and you're looking at these rhythms that your patients have, a lot of times you're going to come across things that you just don't quite know what it is, and you have to often think through it or grab a friend and kind of talk over what's going on and trying to figure out what's happening. All right, so now that we got that one out of the way, let's move on and start to talk about our premature beats that we're going to come across. And there's really 3 kinds of premature beats that we're going to see. And the first of these is what we call premature atrial complexes, or PACs as they'll often be referred to. And basically a PAC is exactly what it sounds like. Basically it's a premature beat that originates from the SA node, or essentially the atria. So in this example, this strip actually has 2 different PACs. The first one you'll find right here, and the next one you'll find right here. And essentially if you look at your strip, you can see normally we have our beats just trucking along right at a regular rate, and then all of a sudden here comes a beat sooner than we'd expect it to be. These are usually pretty easy to spot because typically you'll have that normal regular rate and rhythm, and then all of a sudden occasionally you'll have these beats that just seem to come a little bit earlier than you would expect them to be. Now these are often due to some sort of irritation of the atria, and so this leads to an increase in that automaticity of the atrial muscle tissue. Now a couple of our defining characteristics in order to really be able to identify this as a PAC are: first, it's going to have a narrow QRS. Next, you're going to have an upright P wave. And finally, you could possibly have a different morphology of that P wave. So we'll take a look at our rhythm on the strip here again. And all of these strips that we're going to show you are going to be in lead 2. And that's going to be particularly important because in order to identify a P wave being upright, we're going to need to know that we're looking at lead 2 to know that the P wave should be going up. So here we can see that we have our P wave, and it is in fact upright. We do have our narrow QRS complex, so we can check these off. And in this case, we actually do have a different morphology of the P wave when you compare it to the other ones over here. So again, if we look at this one at the beginning of the strip, this P wave has a different morphology than this P wave here. So in this case, we can check this one off too. Now, I wouldn't rely on this different morphology because sometimes they're going to look much like the normal P waves that you're seeing. But definitely if you have this on top of everything else, it should really help you easily identify that this is a PAC. All right, so the next premature beat that we're going to talk about is our premature junctional complex, or PJC. Now, we are going to talk about this, although one thing to know is this is a pretty rare thing. So it's not something that you're going to see very often as opposed to an actual junctional rhythm, which is something that we're going to talk about a little bit later in this lesson. But a PJC is not something that you're going to typically see very often, so we'll just kind of blow through this one pretty quick. On this strip, we really just have one example of a PJC, which is right here. And just like with the PAC, the PJC is going to be due to some sort of irritation of the AV junction. Now for the PJC, the first thing that we're going to have is another narrow QRS. But really the defining characteristic here is you either have an absent or inverted P wave. So if we go back and look at our strip, you can see we've got that narrow QRS complex. But if you look out here at a normal P wave, you see what we have going on here is this P wave is actually inverted. And like I said, it can either be inverted or sometimes you'll just see a flat isoelectric line before the R wave, but still having that narrow QRS, we can then identify this as a PJC. So moving on to the last premature complex that we're going to talk about, this is going to be our premature ventricular complex, or PVC. Now these are probably the most common one that you're going to see, and I think of the premature complexes probably the easiest to identify. And so on this strip here, I'll go ahead and show you the PVC here. And just like with the others, I bet you can probably figure out this is often due to irritation of the ventricle, and these are typically benign. Now to really talk about the defining characteristics, the first and probably most notable is we're going to have a wide QRS complex. So as you can see here, this is a pretty wide complex that we have here. You're also going to notice that there's not going to be a P wave. Again, we've got nothing over here, which if we think about this as a beat that's originating from the ventricle, therefore you won't see a P wave because the signal didn't start in that SA node and work its way down. And then finally, when we talk about the T wave, we're typically going to have the T wave, which is going in the opposite direction of the R wave. So again, we have our R wave going this way and our T wave going this way. So we have that, we have no P wave, and quite a wide QRS. Therefore, we can determine that this is a premature ventricular complex. Well, hopefully those made sense for you guys. I think identifying those premature beats in those different complexes is usually pretty easy. So next we're going to move on and talk about some of our basic bradycardic and tachycardic rhythms. And the first of these we're going to talk about is sinus bradycardia. And really the first defining characteristic of a sinus brady rhythm is that you're going to have a heart rate that's less than 60. So if you remember, 60 to 100 is our normal rhythm that we would expect in a sinus rhythm. And if we look at our strip here, we see we've got 1, 2, 3, 4 beats in a 6-second strip, meaning we have a heart rate of 40. Therefore, we're less than that normal range of 60 to 100, making this a bradycardia. Now, sometimes the sinus bradycardia can be a normal thing. A prime example of this is going to be our athletes. If you think about, they've built up that strong cardiac muscle and have that real strong contraction and cardiac output. Therefore, the body just doesn't need to beat as often because they're going to get adequate perfusion as a result of that really strong heart. And so sometimes you'll see some bradycardia rhythms in these people. But this could also be a pathological thing. This could be something related to our nervous system, and that nervous system not telling the heart to speed up. This could also be the result of some sort of damage or disease. Think of things like sick sinus syndrome or just damage that results or disease processes that result over time in older people. And finally, this could be the result of some sort of medication. Prime example of this are our beta blockers, which if they've just happened to have too much of the beta blocker in them, this could cause their rate to slow down outside of the normal range. Like we had talked about, you're going to have a heart rate less than 60. In addition to that, you're going to have your narrow QRS and your upright P wave. We already identified our heart rate at being 40. See, we've got our narrow QRS here. And yep, that P wave is upright. Therefore, we meet all the criteria here, and we can identify this as a sinus bradycardia. Now, on to the flip side of sinus bradycardia. Next, we're going to talk about our sinus tachycardia. So once again, we know our normal heart rate is 60 to 100. Therefore, in order to have a sinus tachycardia, we're going to have a heart rate that's greater than 100. So in this example, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 beats in a 6-second strip, meaning we have a heart rate of 140, and that's definitely over 100. Typically, our causes for a sinus tachycardia is usually going to be the result of some sort of increased sympathetic response. So these can be things like your patient's in pain, they have a fever, they have an increased oxygen demand, or even things more serious like hypovolemia. Now, once again, we're calling this a sinus beat. Therefore, we're going to have that narrow QRS and, of course, an upright P wave. So again, if we look at our example, we do have that narrow QRS, and lo and behold, our P wave is upright. And we already talked about our heart rate of 140 is over 100. Therefore, we can say this is a sinus tachycardia. So moving deeper into the territory of our tachycardias, the next one we're going to talk about is our supraventricular tachycardia, or oftentimes you'll hear this one referred to as SVT. And really for SVT, our first defining characteristic is going to be a heart rate that is greater than 150. So in this example, if we count out these here, we see that we actually have 16 beats here. Therefore, we know we've got a heart rate of 160. So we are past that 150 mark, but sometimes with these SVTs, you can see rates as high as 300. Just crazy to think about. Now, you might really be thinking, how is this any different than a sinus tachycardia? Why do we have this distinction of 150? And typically the reason for that is at this point, you're going to end up with an indistinguishable P wave. And really what we mean by that is the rate is happening so fast that we can't really tell if this is the T wave or the P wave. Is there a P wave in there? Is there not? We can't really tell. But we can see that we have a narrow QRS, which you can see here, and therefore we know that this is coming from at least the AV node or higher, because those signals are going quickly through the ventricles, giving us that quick QRS complex. And that's where we get the name supraventricular from, is it's somewhere above the ventricle. but oftentimes we're just not able to tell because that rate is happening so fast. Finally, one last defining characteristic that you're going to have here is that you're going to have a pretty regular rhythm. There's going to be some fluctuation in it with its speed, but for the most part, you're going to be right around in the same area. And you can see that with our rhythm strip here, these R waves are coming at a pretty regular rate. Now, just to hit on the causes real quick, really the causes of our SVT are going to be very similar to sinus tachycardia, and it's primarily due to that increased sympathetic response. But here for this example, heart rate of 160 is greater than 150. Can't really tell if there's a P wave in there. We do have that narrow QRS and a regular rhythm. Therefore, we can say that this is a SVT. All right, I've always really kind of enjoyed those tachyrhythms, especially the SVT. It's pretty interesting when you actually see a patient that has that. And so with that said, I'm actually going to go ahead and stop this lesson at this point before this particular one gets too long. And to kind of conclude, in this lesson we talked about sinus arrhythmia, the 3 different types of premature complexes that you'll see in your patients, as well as the brady and tachycardia rhythms that you're often going to see. And so in the next lesson, we're going to pick up where we left off, and we're going to talk about all the different atrial, junctional, and ventricular rhythms that are out there. All right, you guys, like I said, this is going to be our 4th lesson in this series in which we continue our discussion about arrhythmias. Specifically, in this lesson, we're going to talk about our atrial and junctional arrhythmias. In the last lesson, which is going to be linked to up above, we started our discussion with arrhythmias talking about our sinus arrhythmias, our premature complexes, and our brady and tachyarrhythmias. And so we're going to pick up where we left off, and we're going to start into our atrial arrhythmias. And for those of you who don't know, my name is Eddie Watson, and I will be presenting this lesson for you. And so with that out of the way, let's go ahead and dive into our atrial arrhythmias. And the first and probably one of the most common and well-known rhythms that we're going to see and talk about is going to be atrial fibrillation, or what we often refer to as AFib. And when we talk about AFib, probably one of the most notable things about it is that it's a pretty chaotic rhythm. But within some of that chaos, we do have recognizable QRS complexes. So if we really think about it, we've got a chaotic baseline with these QRS complexes that pop up. And so what's really happening in AFib is you have these atria that are just fibrillating. They don't have this organized contraction, and that's what you're seeing with this chaotic baseline. And so the AV node is just being bombarded with impulses. And as a result, some of these impulses will get through to the AV node, and some of them won't. And AFib is typically the result of some sort of damage to the structure of the heart. This can be as a result of disease process, either acute or chronic, and oftentimes you'll typically see this in your elderly patients. There are a couple of concerns, though, that we have with this rhythm. The first of these is that we're going to lose that atrial kick. So if you remember that atria contracts just before the ventricle does, helping to really fill up that ventricle before it contracts. But since we don't have that organized contraction here, we're not getting that atrial kick. And therefore, we're going to lose about 20% of our preload into that ventricle. And this can have a sometimes profound impact on our patient's blood pressure. The second concern with this is since we don't have that contraction, that blood is often not moving through the atrium as well as it should, and so this puts our patients at risk of thrombus. And if that clot forms and it moves into the ventricle and then out into the circulation, this could potentially cause a problem for our patient. So definitely important to be able to identify this one. So a couple of our defining characteristics for this are we're going to have an absent P wave. And remember, think it's going to be chaotic. And so this is going to be one of our hallmark signs of this. And really, you can see here, we don't have an organized contraction or P wave. You may see things along the way that kind of maybe look like you have a P wave, but really you have that disorganized contraction of the atria. Some parts are contracting a little bit more strongly than others, and sometimes it will give you this false appearance. But if you just look at the rest of the line there, everything is pretty chaotic. Therefore, we can probably be pretty sure that this is AFib. In addition to that, since we know this beat is coming from the atria, we're going to end up with that narrow QRS. But another hallmark of this is its irregularity. You're going to have a pretty irregular rhythm. And so again, we can see that here if we look at the distance here, and we look at the distance here, and then again the distance here. If you just look at it, you can see the irregularity in it. And you're often going to see your heart rate on the rhythm bouncing around. And you can have some pretty wide variances in how often those impulses are getting through that AV node. So like we talked about, we definitely have the irregular rhythm. That QRS complex is going to be a narrow complex. And we certainly showed the chaotic absent P waves. Therefore, with this criteria met, we can define this as a patient being in atrial fibrillation or AFib. All right, so the next rhythm that we are going to talk about is our atrial flutter or A-flutter. And probably right away you can see the difference in our rhythm here than the AFib that we were just looking at. And what's happening in A-flutter is we've developed some sort of re-entry circuit within the atria, and so it creates a loop of the impulse that was originally generated and loops it back to the AV node so that it comes through more frequently than it was supposed to. Now, probably our hallmark sign for A-flutter is going to be our sawtooth P waves. And so if you look at these right here, it almost has the look of the blade of a saw. It has that toothy edge, and you just see that repeating throughout our rhythm here. Now with that, you're typically going to have, if you were to count out the rate for these flutter waves, you're going to have these flutter waves with a rate greater than 250. So these flutter waves are going to be happening pretty frequently. Fortunately, not all of the impulses are going to be passed through that AV node, and we see that happening here as we have flutter waves without a QRS complex. But every so often that impulse will get passed along, and we will have that QRS, which in this case is going to be a narrow QRS. But as I said, it's really that sawtooth appearance of those flutter waves that's really going to be the telltale sign that your patient's in a flutter. Now, this ratio of flutter waves to QRS complexes can vary, and one of the other more common occurrences that we'll see is an A-flutter at a 2-to-1 ratio. And essentially what's happening here is every other flutter wave is making it through as a QRS complex. And so here we can see that flutter wave is happening at a pretty fast rate. And with every other one making it through the AV node, you're going to end up with a heart rate that's pretty fast. Now, sometimes you're going to be able to distinguish this sawtooth appearance in that indistinguishable T wave, P wave, but sometimes you're not, and it's really not going to be any distinguishable from an SVT. And it may require further investigation with either a EKG or even using something like adenosine to slow things down for a bit so you can see what's underlying. Otherwise, the same causes that are going on here in terms of when we're just looking at our normal A-flutter, but I did want to show you guys this so that you can see an example of this and know that it may not actually be SVT. All right, so moving away from the atrium now, we're going to move on to our next rhythm, which is something that we call a junctional rhythm. And so what's happening with a junctional rhythm is our signal or our impulse is actually originating from the AV junction. And so if you really remember from part 1 of this series where we talked about that conduction system and we talked about the AV node also having that same automaticity that the SA node has, but that it has a slightly different rate. And therefore the pacemaker rate that we get from the AV node is actually a rate of 40 to 60. And so that's going to be one of our hallmark signs here, is that we do have that rate of 40 to 60. And so sure enough, in this example, if you count out our QRS complexes, you see that we have 4. Therefore, we know the heart rate in this example is 40. Now, along with this, you're also going to have that narrow QRS. Again, because we're initiating an impulse from above the bundle of His, so that signal is going to move quickly through the ventricle still. But here, like when we talked about with our PJC, we're either going to have an absent or inverted P wave. So once again, if you look at our example here, there's our P wave, and that's definitely upside down. Although you can also sometimes just get a flat isoelectric line that goes across here. But looking at our QRS complex, we definitely do have a narrow QRS complex. And like we talked about, our rate is 40. Therefore, we know that we could classify this as a junctional rhythm. Now, within these junctional rhythms, we do actually technically have 3 different rhythms. We have our normal junctional rhythm. We have what we call accelerated junctional. Or we have what we call junctional tachycardia. And really the only difference between these different junctional rhythms and just a normal junctional rhythm is going to be the heart rate that we find. So in an accelerated junctional, you're actually going to have what appears to be a normal heart rate. So you'll have a heart rate between 60 and 100. And then junctional tachycardia, if you haven't figured it out, is going to have a heart rate greater than 100. And the reason that we can sometimes see these increased heart rates is that the AV node is still impacted by the sympathetic nervous system. So it has direct innervation from the sympathetic nerve, as well as it can be impacted by catecholamines that are released that are going to speed up our heart rate. Or sometimes these can also be caused by some sort of ischemia that's just causing an increase or an enhanced automaticity within that AV node. But otherwise, outside of the heart rate, everything else is going to be the same. You're still going to have that narrow QRS, as well as either those absent or inverted P waves. So definitely be on the lookout for those, because that's really a hallmark sign of our junctional rhythms, is going to be that absent or inverted P wave. All right, and so that sums up our atrial and ventricular rhythms. In this lesson, we talked about the different atrial arrhythmias that you're going to come across, such as AFib and A-flutter, including its 2-to-1 variation, as well as we talked about some of the differences and the things that you're going to see with the various junctional rhythms. Hopefully these explanations made sense for you guys, and again, hopefully this information will be useful for you guys when it comes to interpreting these rhythms within your patient. For the next lesson in this series, we're going to continue our look at arrhythmias, and we're going to move on to the ventricular rhythms. All right, welcome back, you guys. Like I talked about, this is going to be the 5th lesson in this series, covering EKG and ECG interpretation, and we're going to continue on with our coverage of arrhythmias. In the last lesson, we took a look at the atrial and junctional rhythms, but in this lesson, we're going to take a look at those various ventricular rhythms, and these ones are especially important because a few of these can be pretty serious for your patient. And for those of you who don't know, my name is Eddie Watson, and I'll be presenting this lesson for you today. And with that said, let's go ahead and start our dive into our ventricular arrhythmias. And the first of these that we're going to talk about is our idioventricular rhythm, or our IVR. And this idioventricular rhythm is going to be the result of when either the SA node or the AV node are either not firing or not sending their signals down when they are firing, or if they're sending them at such a slow rate that the ventricular intrinsic rate, or the intrinsic rate of the bundle of His or the Purkinje fibers, take over and begin to at least get some sort of contraction and some sort of cardiac output. So just to go over some of the defining characteristics before we talk about this a little bit more, first you're going to have a wide QRS. You're going to have absent P waves. And finally, you're going to have a heart rate that falls within our ventricular intrinsic rate of 20 to 40. Now, this is important to know because at this rate, and without having that atrial kick due to that absent P wave, that this is not usually going to have a sufficient cardiac output. And so this is potentially a life-threatening condition that your patient is in. And so just looking at our example here, you can see we've got that really wide QRS. You can see there's not any P wave anywhere around here. And definitely counting this out, we've got 1, 2, 3, therefore a heart rate of 30. Therefore, we can definitely identify this as an idioventricular rhythm. Now, just like with our junctional rhythms, sometimes you're going to see faster heart rates than what's normally within that intrinsic ventricular rate. And so we do have a couple other variations of this that we're going to talk about. And the first one is called accelerated idioventricular rhythm, or AIVR. And just like with the junctional rhythms, everything about this rhythm is going to be the same as our idioventricular rhythm, other than we're going to have a heart rate between 40 and 100. Now, just like with our junctional rhythm, we can also find ourselves in a situation where we have a ventricular rhythm with a rate that's greater than 100. And that leads us to the next ventricular rhythm that we're going to cover here, our ventricular tachycardia, or oftentimes referred to as VTAC. And in this example here, this is our monomorphic VTAC. And basically what that means is we only have one kind of morphology of ventricular rhythm going on here. As you can see, each of these ventricular rhythms are basically about the same, telling us that this is originating from the same spot. Now with VTAC, this has the potential to be a very serious thing for your patient. You can find a patient, though, who still has a pulse and still is awake and talking while they're in a slow VTAC. But probably more common of what you're going to see is a patient who's pulseless, and therefore this is potentially a lethal rhythm. So it's definitely going to be important that you guys are able to identify this rhythm, because especially in the ICU, unfortunately, you're going to see this one pretty often. There's a few different things that can cause our patient to go into VTAC. The first of these can be myocardial ischemia. You can have an R on T event. Can also happen as a result of cardiac drug toxicity. Ventricular irritation. Or even electrolyte imbalance. So again, some of our defining characteristics for this, we're going to definitely have that wide QRS complex. Again, this is originating from within the ventricle, and that signal is not traveling quickly down that bundle of His and the bundle branches. You're also going to have no discernible P wave. And for this to be VTAC, you've got to have a heart rate greater than 100. And like we said, the patient may still have a pulse with this, typically when we have some of these slower VTACs, but even those can deteriorate pretty quickly and progress into an even more lethal ventricular rhythm, which we'll talk about next. But sometimes you'll see heart rates that are in the 200s or even close to 300 with VTAC. Now, before we move to that next ventricular rhythm, I do want to show another variation of a different kind of VTAC, and this is something that we call torsades, which is essentially our polymorphic VTAC. And the reason we call this polymorphic is because that origination of that irritated ventricular signal is moving around throughout the heart and not coming from the same place. Therefore, if you look at the morphology of, say, these beats here, compared to these beats here, and compared to these beats here, you see that they're quite different, telling us that these impulses are coming from different parts of the heart and therefore being captured differently on our ECG. This is another one of those very interesting rhythms, and more often than not, this is going to be a pulseless rhythm for your patient, so this is also another lethal rhythm, and typically as a result of either prolonged QT or some sort of electrolyte imbalance. That's really about all I'm going to cover on it for the purpose of this lesson, but just know that this is going to be a different form of VTAC that you're going to have to be able to identify. All right, so now we're moving on to the last of the ventricular rhythms that we're going to talk about, and this is one that we call ventricular fibrillation. And this example that we're showing you here is an example of a coarse VFib. Now with VFib, unlike VTAC, there's no chance that your patient's having a pulse with this one. Therefore, this one is absolutely a lethal rhythm and will require immediate intervention on your part. Think here, ACLS and coding your patient. Now, just as the name suggests, ventricular fibrillation is just that, fibrillation of the ventricles. So just like we talked about with atrial fibrillation, those ventricles are not having an organized contraction and they're just quivering or fibrillating, and essentially you're not really getting any sort of blood flow out of the heart. hence this being such an emergency to have to deal with. So it's pretty easy to identify when you're looking at it, but it does have that chaotic rhythm, but you're not going to have any QRS complexes. So again, you've got no cardiac output. I can't stress this enough. Lethal rhythm, you've got to know this one. And this example here, like I said, is a coarse VFib. And the reason that we call this a coarse VFib is because we still have some large, unorganized rhythms going on here. Whereas if we look at the next example here, with our fine ventricular fibrillation, you can now see that you have much smaller tracings on your ECG. And really the reason for this is you have less electrical energy that's happening within the myocardium. And so unfortunately, if you're seeing this in your patient, you probably have less of an opportunity for a successful defibrillation. So hopefully if you are going to see this or encounter this with your patient, that you can catch it early while it's still in that coarse VFib stage, because once we progress to this point, you're going to have a much harder time getting that patient back. All right, on that note, that is going to wrap up this lesson in which we have talked about our ventricular arrhythmias. So we've done a pretty good review of these various ventricular rhythms that you're going to see from our IVR to our AIVR, and then progress that into our ventricular tachycardia or VTach, and some of the different variations that you're going to see with that. And finally, we rounded it out covering ventricular fibrillation or VFib, again in a couple different variants that you're going to see this. But the vast majority of these ventricular rhythms are absolutely vital that you guys are able to recognize these and be able to interpret these, because for the most part, they either require some sort of immediate intervention or will lead to some sort of emergent intervention for your patient, such as initiating ACLS or something to that effect. So very important that you guys know these ones. Hopefully this lesson was able to give you the tools and the knowledge you need to be able to properly interpret these on a rhythm. All right, you guys, welcome back and congratulations on making it to the last lesson in this series of lessons on ECG and EKG rhythm interpretation. Like I said, in this lesson, we're going to cover the various different types of heart blocks that you're going to find your patient in. For those of you who don't know, my name is Eddie Watson, and I'm going to be your presenter for this lesson. All right, so let's go ahead and get into it. And so to start out, heart blocks. They're basically what they sound like. There's some sort of block in the impulse that's going to cause some sort of arrhythmia in your patient. There's several different types of these, and we're going to go through and cover each of them pretty extensively here. But to start us out, I want to talk about our bundle branch blocks. So essentially what's happening with our bundle branch blocks is that we have one of the bundle branch pathways that is blocked and is not allowing for that high-speed signal to get to that side of the heart. And so this causes the depolarization to move very slowly across that ventricle. And there's primarily two types of bundle branch blocks that we're going to worry about. We have our left bundle branch block and our right bundle branch block. Now we're going to talk about each of these here and causes and how you would identify them, but ideally you're going to want a 12 lead in order to truly identify and diagnose a bundle branch block. But you are able to recognize these as well just on your normal bedside monitor, because they're going to manifest themselves as a wide QRS complex with some sort of difference and telltale sign that will really help you to identify is it a left or a right bundle branch block. Now, in all the past examples, we've talked about using lead 2 as our lead to be analyzing and interpreting these rhythms, but specifically if you're suspecting a bundle branch block, you want to be looking at your V lead on the monitor, which is going to line up with what is the V1 lead on a 12-lead EKG. So for the first of these, we're going to talk about our right bundle branch block. And when we're looking at the V lead on our ECG, we're going to see something that looks kind of like either this or perhaps something like this. And so basically what's happening here is because that right ventricle is having to depolarize slowly, you're going to end up with a very quick left-sided depolarization that shows up in the middle of your right ventricle depolarizing. So in this first example, we've got the left side depolarization happening here, while this entire thing is the right-sided depolarization, whereas in this other example here we have our left-sided depolarization all within our right-sided depolarization. And so these right bundle branch blocks can really be caused by a few different things. You can have things affecting the right heart. These can be things like pulmonary hypertension, valvular disease, PE, etc. This can also be the result of conduction system degeneration. This can also be the result of coronary artery disease, or CAD, and this can be either acute or chronic, or it can be from other causes, and these are going to be things like drugs, electrolytes, aberrancies, things of that nature. But the way that we're going to distinguish this right bundle branch block from the left bundle branch block, which we're going to talk about in a second here, is in our V1 lead, we're going to have what we call terminal positive. And essentially what that's saying is the last part of the QRS complex, before we go back to our isoelectric line and onto our T wave, if we have a positive part to it, then we can identify this as a right bundle branch block. So even though we go up and down, here we end up back up again before we come to the isoelectric line, meaning that last part of it was on the positive side of that line, and the same with on this side where we went up, crossed back down, but came back up again at the end before we came back down to that isoelectric line. So you want to pay attention to that last part of the QRS complex. If that last part was positive, then you've got a right bundle branch block. So now moving on to the left bundle branch block, you're going to end up with something that looks like this. So definitely a bit different than what we see in the right bundle branch block, but you might not be able to pinpoint exactly what it is that's different that will be your telltale sign. Perhaps maybe you do, and if you do, awesome job. Now with our left bundle branch block, there again are many causes of this. The first can be something like a cardiomyopathy. It can be from either valvular or hypertensive heart disease. Again, coronary artery disease can be a cause, either acute or chronic. And again, the same conduction system degeneration. Now, when we talk about identifying the left bundle branch as opposed to the right bundle branch, again, we're going to be looking at our V1 lead, but this time we're going to have terminal negative. And again, what that means is before we come back to our isoelectric line, if the last part of our QRS complex was a negative deflection, then we've got a left bundle branch block. And so again, we can see in this example, we go up and then down before coming back up again. The last part was down here negative. Therefore, we know this is a left bundle branch block. And again, like I said, it's important that you guys are looking at your V lead as opposed to lead 2 in order to truly be able to distinguish either a left or a right bundle branch block. And so that's about all I'm going to really cover on these bundle branch blocks. I did want to include them as they are technically fall within that category of being a heart block. But moving on from there, we're going to go ahead and bring up again our 6-second strip for our EKG paper. And for these last remaining heart blocks, we're going to give you examples on here, just like we did in the previous lesson. And so now these blocks that we're going to talk about fall within a category of what we call our AV blocks. And these are going to be the typical heart blocks that you guys are going to encounter and have to be able to identify. Now, these blocks are the ones that oftentimes will cause people trouble when they're trying to analyze these rhythms. They definitely can be difficult, but hopefully by the end of this lesson, you guys will be able to better understand these and understand what's happening and truly be able to identify each of them. The thing to really keep an eye out here is the regularity of the P waves and then the R waves of the QRS complex. It's going to be really important that you guys are measuring the PR interval, which we talked about in the second lesson in this series, in order to truly be able to recognize these. So with that said, let's go ahead and move on to the first of these AV blocks, which just so happens to coincidentally be our first degree AV block. And so to start out, what's happening in a first degree block is we're having a prolonged transition of impulse through the AV junction. So as we talked about, the job of that AV node is to delay that transmission of that impulse, but if it happens to delay that impulse too long, then you end up with a first-degree heart block. So let's just go ahead and list out some of the defining characteristics of a first-degree block, and then we'll talk about what we see on the rhythm strip here. The first of these is going to be that you're going to have a PR interval that's greater than 0.20. And with that, you're going to have regular P waves and regular R waves. And along with that, you're going to end up with a narrow QRS. So let's go ahead and take a look at our rhythm here and see what we've got going on. So first off, we can definitely see we've got a narrow QRS here, so check that one off. Then if we take a look at our P wave, if we were to measure out this PR interval, which goes from here to here, hopefully it's pretty obvious in this example, but we definitely have a PR interval that is well over 0.20 seconds. As you can see, we go across one big box and almost another 5 smaller boxes, so we are definitely elongated here. So if you think about that, impulse is initiating in that SA node, and it's going to the AV node, and it's taking a while, and then finally you have your QRS complex in which that impulse is passed down the bundle of His. Now in addition to that, if we check our P waves, we can see that these P waves march out pretty regularly. In addition to that, our R waves also march out pretty regular. Therefore, we've got our regular P and our regular R with an elongated PR interval greater than 0.20 seconds with that narrow QRS. Therefore, we know that this is a first-degree heart block. Now, I'm going to start off with a little analogy that I've got to give credit where credit is due. This comes from Laura Gasparis in her CCRN review, but she explains these heart blocks as an example of a husband and a wife. And what's happening in a first-degree block is the husband comes home late. And in this example, the husband's the P wave and the wife is the QRS. And in the first-degree heart block, we see we have the husband who comes home every single night, but he's late, and he's late every single time. He's consistently late, but he comes home, and therefore every single time you've got a P wave and a QRS just with that elongated PR interval. All right, so let's go ahead and move on to the next of these AV blocks. And for this is going to be our second-degree heart block. And this is going to be specifically the Mobitz type 1, or what you'll hear commonly referred to as a Winky Bach. And so what's happening with a Winky Bach is you've got this cyclical and progressive conduction delay through the AV junction. So that problem is occurring in the AV node, which still happens to be susceptible to the parasympathetic response. And so what happens is you get this cyclical prolongation of that PR interval, followed by what we call a dropped QRS, which is essentially a P wave without a QRS complex. So to go over our defining characteristics, we're going to have that cyclical prolongation of that PR interval. And again, that's going to be followed by a dropped QRS. And I will explain that in a minute so that it makes sense for you guys. With this, you're going to notice irregular QRSs, but still you're going to have that narrow QRS. And just to cover some of our potential causes of this, it could be as a result of increased vagal tone, could be from myocardial ischemia, or it could be from the effect of drugs. Think of things like our calcium channel or beta blockers or even digoxin. Now, I did also forget to mention real quick, along with that irregular QRS, you're also going to have an irregular P. So let's take a look at this and see what we have going on. So first, if we look at our first beat that we have here, we've got what appears to be a normal PR interval. As well, you've got that normal QRS complex. But as we go on to this next beat here, we can see that that PR interval has gotten longer. And again, if we go on to this next one, we see that that PR interval is even longer. Until finally we have this lonely P wave and no QRS complex. Where the heck did it go? Well, this is what we call that dropped QRS. So we had that cyclical prolongation of the PR interval, so that conduction of that signal became longer and longer and longer until eventually we dropped it and we no longer pass that signal through. Therefore, you don't end up with a QRS complex. And then just like clockwork, things restart back again, and we end up with a short and then a longer, and if we kept going on, you would see a longer before another dropped beat. Now, it's a little bit hard in this example to identify some of the irregularity in the P wave, so it definitely would be helpful to have that piece of paper or note card with you. But we do have irregularity in these P waves. They're not coming at a regular frequency. And definitely, hopefully, with these QRSs, you can certainly see the irregularity as this and this are quite a bit different. Now, to take it back to the husband and wife reference, in this example, we've got the husband who first comes home normal, then he comes home a little bit later, and the next night he comes home a little bit later, until finally the last night, he just doesn't even come home. And that's essentially what's happening as we have that PR interval that gets longer and longer and longer, and finally it just doesn't get through. And so with these second degree AV blocks, there's actually another one, a Mobitz 2, which we're going to cover in a second here. But one of the ways to help you really remember that this is a Winky Bach is there's a little phrase that you can say that actually a friend of mine taught me way back in nursing school that has really kind of stuck with me. And it's longer, longer, longer drop, then you have a Winky Bach. So it's got a nice little ring to it. Hopefully that'll help you guys remember that when you have this going on, this is a Winky Bach or a Mobitz 1. All right, so moving on, I already pretty much alluded to what's coming up next, and that's going to be our other second degree block, which is a Mobitz type 2. Now this one doesn't have a fancy name like the Winky Bach, so you just have to remember if it's not a Winky Bach, it's type 2, but this is an example of it here. Essentially what's happening in a Mobitz 2 is we have some sort of intermittent block that happens below the AV node. So it's not going to be a cyclical thing like we saw with the Mobitz 1 or the Winky Bach. And this problem is actually occurring below the AV node, so somewhere in that top portion of the bundle of His, and therefore we don't have input from our parasympathetic fibers. Some of our defining characteristics for a Mobitz 2 are you're going to have a fixed PR interval, you're still going to have a narrow QRS, but you're going to have occasional dropped beats. And for this one, you're going to end up with regular P waves, but irregular R waves. But an important thing with this rhythm before we jump into really kind of explaining this is this one's going to really require close monitoring. And the reason for this is depending on how frequently we're having these dropped beats, we have the potential to have a low cardiac output as a result of that. And even more concerning is while this is an incomplete or an intermittent block, it could progress into a complete heart block, which we are going to talk about next. So here, kind of looking at our rhythm strip, if we look at our examples, in our first beat, we've got a normal PR, here we've got another normal PR, here we've got another normal PR, but then all of a sudden we have this lonely P wave without a QRS complex, therefore this is one of our dropped beats. Again, we've got our normal QRSs here, and if you think about what's happening here, is we have this signal which is originating in the SA node, and most of the time it reaches the AV node, goes through the normal delay, and gets passed right along. But every so often, we run into a problem, and that signal or that impulse just does not get passed along. And that's where we end up having these random dropped beats. Now again, if these are happening every so often, you're not going to see much impact on your cardiac output. But if you start having a lot of these dropped beats, well, you're going to be drastically reducing your heart rate and thus drastically reducing your cardiac output. So here we kind of talked about our fixed PR intervals, our narrow QRS, having our occasional dropped beats. And then if you look at our P waves, you can see that these just march right along at a regular rate, and some of them get through and some of them don't. Whereas if we look at our R waves, we can definitely see we've got some irregularity based on these wide differences we see here. And so with all these criteria met, we know that this would be a second-degree heart block, a Mobitz type 2. And again, to go back to our husband and wife analogy, in this analogy, essentially sometimes the husband comes home and sometimes he doesn't. When he does come home, though, he always comes home at the same time, but occasionally he just doesn't come home. All right, and so now to move on to the last of these heart blocks, this is going to be what we call a third-degree AV block or a complete heart block. And so just as the name suggests, that this results from the complete block of impulse from the AV node to the ventricles. And an important thing to know when you have a patient that goes into a complete heart block is this is often going to result in hemodynamic compromise. And so really to kind of explain what's happening here is we do have an impulse that's originating in the SA node and it's firing along and it's all happening at a pretty regular rate, but absolutely none of those are making it through to the ventricle. And so the ventricle has had to pick up its own intrinsic rate in order to provide some sort of cardiac output, but which oftentimes is not going to be sufficient for your patient. And so you're going to just see these lonely P waves just marching out regularly, but no real associated QRS complex. And so this is going to lead to a chaotic PR interval. Now along with that, you have the ventricle, which has picked up its own intrinsic rate, and so that's going to be marching along pretty regularly. But instead of that normal narrow QRS, we're going to have that wide QRS. So again, think about those ventricular rhythms or on the PVC. That's what you're going to see here. And so with this, you're going to have regular P waves and regular R waves. But they're just going to be going on and doing their own thing and not having any kind of communication with each other. Like I said, due to that decreased cardiac output and that hemodynamic compromise, this is often going to require some sort of immediate intervention, typically pacing. So if we take a look at our rhythm, we're going to look for our P waves and see if we can find them all. So here we have one. Here we also have one that gets buried in that QRS. Here's another one. Here's another one. This one's kind of buried within that QRS. Another one, another one, another one, and another one. So if you look, these dots march themselves out pretty nicely. So we do have those regular P waves happening. But if we take a look at our PR interval, here we've got a really long one. Here we've got a kind of long one. Here's a short one. Over here would be the start of another really long one. So we really just have that chaotic PR interval that just doesn't seem to be making any sense. In addition to that, we do have that wide QRS complex here, which should help to be a telltale sign that you've got some sort of complete heart block going on here. And as well, we do have our R waves, which are marching along nicely here. So we had that chaotic PR interval, wide QRS, and regular P and regular R. But as you can see, they're just doing their own thing, and each one is just doing what they need to do and not having any kind of communication with each other. And to bring this back to our husband and wife reference, that's exactly what would be happening here, is the husband and wife are just doing their own thing, coming and going at their own schedule without any interaction with each other. All right, and so that is going to conclude our talk here on the various different heart blocks. Like I said, I know these ones can be tricky to identify, but if you really kind of think about some of those criteria that we talked about, each one of these has a pretty unique set of criteria. So if you just think through what you're seeing and take your time with it, I promise you that you guys can figure this out. And so with concluding that, that's also going to conclude this last lesson in this series on ECG and EKG rhythm interpretation. Hopefully going through these 4 lessons has really helped to build a solid foundation for you guys, because it's an essential ability that you have to have in working in the ICU, in being able to look at your patient's rhythm and identify what's going on, because sometimes these interventions require immediate action. But eventually, if you do this and you put the time in, you will reach a point to where you can just look at these and pretty quickly be able to interpret these rhythms, and they will be much less stressful when you actually see them happening in real life. Minus, of course, the identification of some of these rhythms, which mean that your patient, as well as you, are about to be having a pretty bad day.